Well, gee, I simply said, try not to go over your 20 minutes so I don't have to give you a 2-minute card because that would embarrass me. But I didn't expect you to go less than 20 minutes. So now the burden is on all of us to ask these wonderful 3 panelists some burning questions. And I think we can open it up. Doesn't necessarily have to be specifically to the absolute roles that we have listed here, but maybe you have just some questions in general that one of the 3 might be able to take. And if not, then I'm going to start shooting questions. And that's not something you want to do because I may also end up answering some of those questions myself because I can't help it. So please feel free to take the microphone and begin asking your questions. Thank you, gentlemen, all 3 of you. Thank you very much. Well, we will begin from the right, as is the sunnah.
Molly, go ahead.
Okay, so going by the sunnah. Sure. Okay, I'm actually going to stick to the topics, and I'm going to ask Dr. Jones and Dr. Barnowski each separate questions. So, Dr. Jones, say one of these young doctors are inspired, they're inspired by your talk, and they raise $50 million for you to start your own Islamic seminary to train chaplains, and you can design the seminary as you like. What do you imagine the Islamic chaplain's role will be in bioethics? I mean, we heard from the conference this tension of, what should the doctor's responsibility be, what should be the Islamic scholar's responsibility. And a lot of Islamic chaplains currently kind of push back and they say, we're not scholars, we're not even imams, and so we're not religious authorities. So there's kind of a resistance of the current Islamic chaplains to provide fatwas or even recommendations in terms of what does Islam have to say about various bioethical issues. For an Islamic hospital chaplain, what could you imagine your role would be for in terms of bioethics when you consult? That's my question for Dr. Jones. For Dr. Barnowski, along the same kind of lines of my grandiosity, if we were to imagine a kind of Islamic work group that wanted to provide bioethic recommendations online, I mean, what are the kind of legal or, in other words, there's a work group, let's say, based in the University of Chicago, that they provide a service for people who, at University of Michigan, you have a Muslim patient, you don't know the bioethics question. Can you imagine an online service from distantly, for like a work group for Islamic bioethics? Are there kind of barriers to that, legal barriers? Or since ethical recommendations are non-binding, are there restrictions, or is that something that could be feasible? Kind of an online bioethics, Islamic bioethics work group that can give recommendations to ethical committees? Thank you.
So why don't we take the first question?
Sure. I would think a Muslim chaplain has 3 roles. As I saw it in the prison, because most of my experience has been in the prison, I've just begun to work in the hospital setting and mainly as a clinical supervisor. One is presence. Just by being there, and I know this seems too obvious, but reflecting the kind of more interfaith and accepting. I mean, because the problem is that we have a PR problem in the United States of America, and that, like it or not, when we go into institutions and when people see us, particularly if we dress differently, as some of us do, people have some notions about who we are. And I think that we need to go overboard with the being good to neighbors thing. When somebody greets you with a better word. I mean, I think that's extremely important, that we make it clear that we're part of the team, we're going to be present there. The second Islamic paradigm, that is, and this is the educational part, is that helping people understand how Islamic principles play out in terms of compassionate care. I mean, again, this is something that people almost never hear about when it comes to Islam. And so in the short run, what the chaplain is going to be in a teaching role. The third is advocacy. When that time comes, when a patient cannot get the food that they need, or they feel like their modesty. Modesty is a big thing for Muslims. There's an authentic tradition of Prophet Muhammad, peace be upon him, that all religions have their characteristics, and the characteristics of Islam is modesty. Well, it's very difficult to be modest when you have one of these gowns on and your back is out. But people still try. Men and women, people think it's only women, but men and women have this issue. And so my point about this is that you need to be able to do those three things aside from offer pastoral care. I mean, because people are going to be looking for pastoral care. And in the area of bioethics, I think it's the second that I outlined as most important. That is, and we're just beginning to do this. I mean, we have people who are writing about this, writing books about this. We need to bring it to the ground level. That is, intellectuals are talking about it, but the average Muslim doesn't know a lot of the writing that's available, and it needs to be translated into everyday language because the doctors don't have time to read the books and the papers. And so those are the things I think would a Muslim chaplain would need to do.
You know, the question regarding would a Muslim-based online internet advocacy ethics consult partner be valuable, you know, I think someone would have to look at that and say, well, you know, certainly it would be valuable. But I think in some circumstances, it's very much like a telephone interpreter service in the emergency department. Would you rather have a telephone interpreter services, or would you rather have an interpreter? And I think under all circumstances, you would much rather have an interpreter. I think one of the things that was brought out very well this morning is that there is truly a very diverse plurality of traditions, beliefs, and practices within the Muslim community. And to the extent that one would rely on someone who cannot necessarily interact with the patient, there certainly could be differences of opinion, I would imagine, depending on who one might have a tendency of interacting with. You know, in this particular type of environment geographically, I mean, I think that we are all in this together from the standpoint of caring for other human beings. Whether one is a physician or whether one is in the clergy or different roles that people have that come forward in dealing with patients in pain, patients involving end of life, whether one approaches it from the medical side, the nursing side, the palliative care side, the ethics side, or the clergy spirituality side. You know, it would be good if we could come together in this regard. And, you know, there's no question that when one is trying to work through issues involving diverse cultures, that having someone who can serve as an effective cultural broker is extremely valuable. But oftentimes, in spite of the best efforts of people providing care, it's hard to identify them, and it's hard to seek them out. And, you know, it would be really worthwhile, I think, if people who have this skill set and a willingness to serve out of simply a passion for the work that's being done could notify healthcare institutions and tell them that if you're ever involved in this particular type of situation, I am willing to help. And then I think that, you know, some of these aspects could be addressed far more appropriately. We have a chaplaincy service at the University of Michigan that has 5 chaplains. They're of different faiths, and I think it's impossible to certainly cover every faith and every sect of every faith through an institutional chaplaincy program. It requires a large number of people. I think that type of a system would be really worthwhile as it was described, but I think it would be second best to some of the things that we could do if we really put our minds to it.
Thank you all for your presentations. A couple of questions, Dr. Barnowski. Just a point of clarification, I wasn't sure that the system that you have set up at University of Michigan, if that information is available for public consumption, and if for public to access or for others outside of the university system to access and benefit from it, and if so, what are some of the pitfalls such as privacy issues and so on and so forth beyond HIPAA? One other point of question regarding what Dr. Jones mentioned, and Mr. Alawan, if you can chime into it as well. You rightly pointed out that one size does not fit all. You have Muslims that are more secular inclination, and certainly those who are more religiously inclined. Nevertheless, when you are advising, Mr. Alawan, for example, if you're advising a patient on a certain issue, medical issue, your precepts are all informed by your Islamic ethical considerations, though they are necessarily universal and the same vis-a-vis organ transplantation or brain death issues. So if you have any comments on that, I'd appreciate your outlook on that. Thank you.
My question is probably the easier of the two and the quicker to answer, and that is that most of the things on the webpage that we have for the Ethics Committee are accessible, but not the consults. So if someone wanted to go get our policies regarding withholding, withdrawal of care, feudal care, and those types of things, those are all available and could be, utilized by other institutions if they chose to do so, or for educational reasons, et cetera. When our consults are done, they ultimately become part of CareWeb, which here is the electronic medical record at the University of Michigan, and it would be listed as an ethics consultation. So it would be in the same way as one would scrolling through and find a GI consultation or a neurology consultation, a history and physical and discharge summary, et cetera. Those things would be visible for anyone who was involved in providing care. And certainly if someone were to scroll through the record on a second or third admission and found out that an ethics consult was done at that point in time, it would be visible. But it would really be visible in the same way that any other type of consultation or elements of the protected medical record would be visible to people who have an interest to know. So.
I think the problem is that when I talk to people, most of the time when I talk to people in the hospital, they're not asking me ethical questions. They want to be, they want to find somebody Muslim to talk to, right? So they're looking for pastoral care. When they do, it's not a big problem in the sense that if it's something very simple, I answer. If it's generally understood, I answer it. If it's not, I'll tell them, and I try to get back to people in a 24-hour cycle. Let me just add something else. I think that in this day and age, if you're in the healthcare system, you're on the staff as a doctor or a nurse or a personal care assistant, that I think you have an obligation to do some of the things that need to be done in the absence of a chaplain. Let me give you an extreme example of it. Dr. Izzeldin Abuleish, who's from Gaza, released a book called I Shall Not Hate in January of this year. I happen to know him. I've known him for about 5 or 6 years. Some of you who follow the news know that during the Gaza incursion, literally he got on national Israeli TV after his daughters and his niece were killed in his apartment, and it's all over. I mean, this is a guy who doesn't go around talking about Islam all the time. But if you read his book, I Shall Not Hate, you'll understand that Islam informs what he teaches his daughters. I mean, it doesn't seem appropriate here, except in the sense that in the United States right now, Islam is under siege in the public square. And so for some of us, it'll be easy for us to go underground, as it were. Those of us who are not clearly identified, who don't wear, something like this or wear hijab. I mean, but I think that we have an obligation, given the kind of situation that we find ourselves in, when we're on the staff of an institution such as a healthcare institution, to do some of the things that I talked about, that is to be present as a Muslim and to exude, not to I'm a Muslim, I'm doing it because oftentimes people say, well, why do you do that? Why are you so nice to people? This is what Muslims do. I mean, I've had this situation at work, and also you end up educating people as well, because people need to be educated. I'm not paid to do this kind of job. So I want to say that, in terms of bioethical issues, I have enough people in New Haven that are in the medical profession, like Dr. Mata, or people who are much more knowledgeable than me in Islam, that I can access for that. And so within 24 hours, I can get a consult for that. I think the bigger issue is for us making sure that we have a positive presence in that institution, because to the extent that we on the staff, make positive contributions to the institution, it will be better for the patient. Do you follow me? In other words, if we're seen as valuable, it will help the patients.
I'd like to thank all the panelists and Najah for moderating this session. I just graduated from medical school, and one of the feedbacks I just was wondering if I could have any of the panelists' recommendations regarding was, more of this agency, as you were mentioning, Professor Jones, taking proactive measures to accommodate patients in the healthcare setting. And one thing that I noticed that was very basic, that was lacking, was simply to recognize that should I be having a Muslim patient in the hospital, that taking certain kind of proactive measures would be very beneficial, such as possibly asking if they would like to have a prayer timetable or indicating the direction of the prayer. I mean, basic measures such as that would definitely go a long way in accommodating patients, and I find that hospitals have been exceptionally accommodating, but I've seen almost an absence of Muslim chaplaincy presence maybe, or Muslim presence period in maybe filling in those gaps. I'm wondering, why not more of a proactive measure? And one place where this could come in, for example, is if patients are registering. I know most hospitals ask for patient religion, and sometimes we ignore that. And this is possibly where a follow-up question could be addressed is, would you like supplemental information pertaining to your religion, whether you're Christian, Jewish, or Muslim? And that would accordingly imply, if you're Muslim, prayer direction, prayer carpet, times of prayers. I think this applies to a vast number of patients in the hospital setting who might not necessarily be end of life, but who would still feel much better accommodated. If you could all comment, or whosoever would like. Thank you.
One moment, please. So we're coming down to the last 4 minutes of this panel, and I'm all about the voice. So I'm going to ask you three to keep your very brief. We'll hear the two of you be very brief, ask questions, and then let them respond, and we're going to tie up the session. So 4 minutes for all. Thank you.
I think it's very important that all the things that the doctor mentioned be there. As I said, I understand the University of Michigan has the direction of Mecca already designated. Prayer schedules are very important. I do pass those out. I don't know about the prayer rugs because most of the patients are bedridden. But direction of Mecca and prayer schedule are very definite. We need the doctors also to get the nurses to understand these things are needed, because sometimes the hospital administration doesn't see the need of it. They figure there's only 1-2 Muslims in there. But when it comes time of death, the nurse needs to know what direction to help the family turn that bed and why they're doing it.
Just very quickly, I think that there's more and more which is being done in undergraduate medical education in terms of the concept of taking a spiritual history as part of doing a history and physical examination. The degree to which that has penetrance into students and faculty and physicians in training alike remains to be seen, but it seems that it becomes more and more a part of the culture. I think the bigger question is that if you do that and you do identify that there are religious needs within the patients that you're serving, is the institution, from the standpoint of having people willing to take the baton from you once you identify needs, willing to come forward, will there be Muslim chaplains and other individuals in different religious groups who can ultimately fill that need?
I just would add, I don't think it's the doctor's role. You might not be implying that to ask these questions for obvious reasons. I think the doctor, the Muslim doctor, can help in peer-to-peer relationships, that is with the staff, and consulting and supporting. But I think for obvious reasons, I don't think, as a professor, I have students who identify as Muslims whose practice spans the spectrum, and I don't think it's my role to ask them or offer, because I think it gets into a tricky, professional area. But with my peers, I do. That is, the other people on staff and student activities that would like that.
So we'll do one moment and one moment, and so, please.
Thank you very much, Steve Modell, School of Public Health. What percentage of the consultation cases revolve around explicitly religious issues? And since it is a public university, how are these wrestled with?
It's actually a minority, I think. I mean, from the standpoint of explicit requests or preferences which are brought forward in the consults that we have done. And yet, when issues are brought forward in that regard, I think that, those requests are accommodated. I mean, certainly from the standpoint of honoring patients' preferences in terms of patient autonomy one necessarily tries to do that. That may at times involve enlisting members of the clergy, and sometimes not. But then again, you know, I think that our religion and our sense of spirituality drives many things, and particularly can drive many things near the end of life, even though it may not be brought out or categorized as such, that it can be, you know, something which nonetheless is driving requests. But from explicitly, I would say it's a minority. Yeah.
Yes, when a patient is admitted in the intensive care, and oftentimes with the coma, cardiac arrest, respirator, the family is looking for some comfort, yes, but at the same time they are really asking more of a religious advice and guidelines. Where do we go? Especially the terminally ill. And at the same time, the transplant team is hounding them with indirect suggestion, well, this is futile, it's not going to do. I've been confronted with this situation many times. Patient's family has called, this is the situation, this is what the neurologists say, this is what the cardiologists say, what do we do? So we withdraw that. So the chaplaincy who is going to be trained in things is not just only a comfort thing, they must learn the fundamental working knowledge of cardiology, pulmonology, and the neurology in the terminal aspect of that. Because if they don't have, so that they can understand the language when they are being told, this is the situation, and you give us advice. Because patient's family, especially the Muslims, are not looking just for comfort. They're looking some religious advice. Should I go along with what the doctor is suggesting? And the doctors are suggesting what the hospital policies are. As you know, the standard of care in many good university centers are, if the transplant team can produce 75% of patients for the transplant, is considered a good center. So my suggestion is that the chaplaincy program should consider these, which you call the critical care, turning into the donor care, which is wrong.
Thank you all, gentlemen. Do you have a comment?
Yeah. Actually, this is done, ACPE, they have a training program, they have a residency program, and there's a didactic portion that includes introduction to the culture of the hospital and certain departments of the hospital. You do rounds like a physician does. And so if a person is formally trained through ACPE, he or she will get the basics and will understand the language of what a doctor is talking about. But inshallah, we'll get there soon.
I just wanted to make one closing comment based on the last question. I think it's important. You know, ethics committees and I think ethics consultation traditionally has also carried part of the weight of palliative care. And I think as palliative care continues to grow in the United States, we have a palliative care consultation service at the University of Michigan. When that first came about, we had a big drop in the number of ethics consults that we did. And part of the reason is that we were doing, a lot of times an ethics committee would be called when what was really needed was that someone was interested in having some guidance from going to aggressive models of care to more of palliative models of care. It's not really an ethical question per se, but you know, someone who would be involved in this work could nonetheless facilitate some of the elements of discussions and working with families and so forth. And so I think the question of, you know, the University of Michigan being a public university and how does one cater to the religious needs of patients at this point in time probably is, it certainly is something that is dealt with in ethics consultation, but it's dealt with in a very large part, I think, in palliative care and palliative care consultation, which is something that continues to evolve as palliative care has an increasing presence in American medicine.